Hello and Assalamualaikum. We are Preclinical students from UiTM and we will be demonstrating abdominal examination procedure for medical students. This video will include the examination of the followings on the slide. Prior to the examination, there are etiquettes and preparation that are ought to be followed in order. First, introduce yourself and then confirm the patient's details. Then, wash both hands in the presence of the patient and gain consent to proceed with the examination. Make sure your patient is comfortable and adequately exposed. And lastly, ask the patient if they have any pain before proceeding with the clinical examination. Afterwards, we can start the examination involving the upper limb. So the hands provide lots of clinically relevant information, but generally you should inspect the palms for a sign of pallor, which suggests underlying anemia, and palmar erythema that can be associated with chronic liver disease. On the dorsal aspect of the hand, inspect the nails for koilonychia, which is also known as spoon-shaped nails, as well as leukonychia, which is the whitening of the nail bed. Then, assess for finger clubbing that is known to be associated with several underlying disease processes. Afterwards, ask the patient to stretch their arms out and cock their hand backward at the wrist joint and hold the position for 30 seconds. This is to observe for any evidence of flapping tremor, also known as hysteresis. Next, you can also palpate the hands to assess its temperature as well as palpate the patient's radial pulse to assess the rate and rhythm. Moving on to face examination. First, inspect the eyes by gently pulling down their lower eyelid and check for conjunctival pallor, which suggests underlying anemia. Then look for evidence of jaundice in the eye or xanthelasma, which is a raised cholesterol-rich deposit around the eye. Afterwards, inspect the mouth to look at overall oral hygiene. Then, palpate the varicose lymph node located at left supraclavicular fossa to check for evidence of lymphadenopathy.
Lie the patient flat. Ensure the patient is at eye level. Examine the chest as well for evidence of gynecomastia, spider nevi, and any loss of axillary hair. Explain to the patient you will be palpating the patient's abdomen. Palpate all 9 quadrants. Is there any pain or suspected pathology? Start in the quadrant opposite this. Otherwise, start in the left iliac fossa and palpate in sequential and ordered manner as shown in the video. Start with light palpation using one hand and move on to deeper palpation using both hands. Try to appreciate for any underlying mass. Next, palpate for the liver edge. Gradually slide your hand from right iliac fossa to the right hypochondrium with every inspiratory effort taken by the patient. Liver palpation. Why must patient inspire? This is because the liver will move inferiorly with inspiration, making it easier to palpate. The diaphragm will push the liver downward. The findings. Tenderness. The normal liver may be slightly tender. Greater tenderness will suggest inflammation, example hepatitis, or congestion, example congestive heart disease. Next, consistency. If there is firm or bluntness or rounding or irregularity of liver, this is suggests an abnormality. If there is like obstructed and distended gallbladder, this may be probable on the inferior liver edge. And if there is tumor or malignancy, there are presence of nodules, and these nodules may be palpable. It is not hard and umbilicated nodules. Next, liver percussion. Percuss for the liver edge. Again, starting from right iliac fossa to the right hypochondrium. Next, palpate from chest downward to look for the upper border of the liver. Using the tape measure, measure the liver span. Liver percussion. The purpose of liver percussion is to measure the liver size. The findings is the liver span. There are 2 lines which are mid-clavicular line and mid-sternal line. For the midclavicular line, it is normally 6 to 12 cm, while for the mid-sternum line, it is normally 4 to 8 cm. Right pleural effusion and consolidated lung give false positive for enlarged liver span, and COPD, which is the chronic obstructive pulmonary disease, may depress diaphragm, and hence it will depress the liver borders but not the liver span.
Next, we will proceed with the palpation of spleen. For this examination, it will involve a few steps. The palpation will begin in the area of right iliac fossa and move upward, gradually sliding your hand with every inspiratory effort to the left hypochondrium. The purpose of the palpation of the spleen to detect any enlargement of the spleen, which is splenomegaly. There have a few causes of splenomegaly, for example, chronic myeloid leukemia, thalassemia, hemolytic anemia, and idiopathic myelofibrosis. Percussion of the spleen. Percussion of the spleen also begin from the right iliac fossa to the left hypochondrium. The purpose to perform percussion of the spleen to detect any enlargement of the spleen, which is splenomegaly. Splenomegaly is suspected if the percussion note is dull on complete inspiration. Then, the palpation should be repeated. Blotting of the kidneys. We will begin with the left kidney and then proceed with the right kidneys. Right hand is slide underneath the renal angle. Flex the finger at the metacarpophalangeal joints to push the content of the abdomen anteriorly, while place the left hand on the top of abdomen at renal angle to palpate for the kidney. Normally, in an adult, the kidneys are not usually palpable, except the inferior pole of the right kidney. Left kidney is rarely palpable. An easily palpable or tender kidney is abnormal. However, the right kidney is frequently palpable in a very thin patient and children.
Is there any suspicion of abdominal distension? Shifting dullness can be elicited. First, percuss the abdomen from the umbilical region, moving laterally towards left hypochondrium and lateral abdominal region. If there is any changes in the percussion from being resonant to dull, get the patient to roll in the right lateral position. After 30 to 60 seconds, we percuss the left lateral abdominal region. If there is change in resonance, shifting dullness is demonstrated. Auscultation of the abdomen performed for detection of altered bowel sounds. The bowel sounds are classified into normal, hyperactive, and hyperactive. If bowel sounds are hypoactive or hyperactive and there are other abnormal symptoms, the patient should continue to follow up. For instance, no bowel sounds after a period of hyperactive bowel sounds can mean there is a rupture of the intestines or strangulation of the bowel and necrosis of the bowel tissue. And also, very high-pitched bowel sounds may be a sign of early bowel obstruction.
Examination of edema. In the first picture, it shows the pitting edema assessment will be handled. First, we will apply the pressure to the anterior aspect of the tibia for 15 seconds and then release. Look for persistence of the depressed area after pressure is removed. While in the second picture, it shows the appearance of pitting edema.
And that is all. Thank you for watching.